surgery as a visiting faculty member. So Dr. Kramer is from the Midwest, hails from Minnesota. Yes, but as she said today, she bleeds blue, and so has spent most of her time at the University of Michigan as a Ohio State Buckeye who bleeds scarlet and gray. I won't hold that against you. We'll still collaborate for many years, I'm sure.
I did not know
I know.
that.
Now we're not friends. So she did her undergraduate and graduate training at University of Michigan and not your undergraduate.
Undergrad in Duluth, actually,
Right, yeah.
Minnesota.
But her postdoc training was with Dr. Randy Seeley, who was on my PhD thesis training committee and who has just been really a master in studying mechanisms of metabolic surgery and metabolism and obesity treatment. So we're going to hear a lot of different talks today, but primarily her lab is studying the pancreas, gut, liver axis, with interest in multiple obesity-associated metabolic conditions, which do include type 2 diabetes and NASH, now known as MASH, as I try to say that correctly, and the effects of rapid weight loss, whether that's through diet or pharmacologic therapy or metabolic surgery. She is funded by a VA Career Development Award and has also many different other funding mechanisms. And I'm delighted to have you here at MCW and looking forward to dinner tonight. So thank you.
Thank you so much for hosting me. Huge thank you to Dr. Kendall. And also huge thank you to Miss Angela Parrish for doing all the accommodations and arranging this trip.
I didn't turn the mic on.
Oh, yeah, I can do it.
Yeah, hit that off.
Just push. Perfect. So before I begin, just this quick disclosures. Part of this work, the published part of this work that I will start with, was supported by Novo Nordisk. And one of the research reagents that I will show today was a gift from Mirum Pharmaceuticals. So what I'm really interested in is understanding the positive metabolic effects of metabolic surgery. And as all of you, I'm sure, are aware, metabolic surgeries come in different flavors. Here, I'm showing two of the most commonly performed surgeries, the vertical sleeve gastrectomy and Roux-en-Y gastric bypass. And even though these operations are very anatomically different, they both lead to rapid weight loss, and that is associated with great reduction in adiposity. We have reduced energy intake, as well as improved glucose tolerance and improved insulin sensitivity. And we also see increase in incretin response, incretins like GLP-1. So before I go on further, this is something that I inserted the slide sort of last minute because this is a question that I've been getting a lot. And mostly because we live in this really exciting time of obesity treatments, such as semaglutide, tirzepatide, and a lot of GLP-1 are agonists and dual agonists being available. So the question that I get often is, why do we care about bariatric surgery when we have semaglutide? So this is a perspective published by Kevin Ho in Obesity just a couple of months ago that I think really put this in illustrations and really put perspective on why bariatric surgery is still the most successful treatment for obesity. So what I'm showing here today is weight loss intervention by dietary modulation. Here we have the Calorie phase 2 trials, which is a caloric restriction, diet fits, which is a micronutrient regulation. In both of these, what we call diet interventions, lifestyle interventions, we have about 10% reduction in body weight. Now we have tirzepatide, semaglutide. We can improve that weight loss to about 20% reduction. However, Roux-en-Y gastric bypass will reduce body weight at about 30%. And not only this, the point that I wanted to make is this is a sustained weight loss. This is not dependent on insurance coverage. We discussed this with a lot of your colleagues today. It is not dependent on whether this prescription is available at the pharmacy. So again, sustained and very potent weight loss. As Dr. Kindo said, I did my postdoc with Dr. Randy Seeley, and I still work with Dr. Seeley very closely. And what our lab has done is establish rodent models of vertical sleeve gastrectomy. And just as I showed you in the humans, in our mouse model of sleeve, we do see a potent weight loss reduction, and that is mostly due to reduction in fat mass. We do see then the initial reduction in energy intake. So as you can see in this figure, I think my pointer's right here, the VSG mice consume less food initially after surgery. However, about 3 to 4 weeks after surgery, they will normalize their food intake to that of sham mice. However, their weight remains lower. We also see improved glucose tolerance through increased insulin secretion. But what I would like to discuss today, and this is really the topic of the today's talk, is this phenomena that we and others have reported, where we see increased systemic bile acid levels after surgery. And this is very surgery dependent observation, because when we pair feed animals, sham animals, to the same weight as vertical sleeve gastrectomy animals, we do not see this increase in systemic bile acids. In addition to increase in the levels of bile acids, this is a rodent model of sleeve, we also see changes in the bile acid composition. And this is also true in human patients. This is baseline, 6 and 12 months after surgery. We do see the increase in bile acids, and we also see changes in the bile acid composition. So just very brief review of bile acids. We can talk about bile acids for a while, but bile acids are synthesized in the liver from cholesterol. We have the 2 primary bile acids, cholic acid and deoxycholic acid. And the mouse also has murocholic acid as one of the primary bile acids. But they're synthesized in the liver. They're conjugated to taurine or glycine in the liver. And this is how they're secreted in the duodenum in response to a meal. However, in the gut, they will be processed, they'll be deconjugated, and they'll be dehydroxylated by bacteria to form secondary bile acids. And one of the main functions, and the first thing that we think of when we think of bile acids is that they aid intestinal lipid absorption. But in addition to this, they act as substrates. And just as I said, the primary bile acids will be deconjugated, dehydroxylated in the gut, turn into secondary bile acids, and this is done by the gut microbiome. And in turn, the gut microbiome can also alter the bile acid composition in the gut. And last but not least, the last 30 years of bile acid research has really shown that bile acids can also act as signaling factors. In 2 of the signaling pathways that we mostly refer to as bile acid signaling pathways act through the G protein coupled receptor TGR5 and the nuclear receptor FXR. The Seeley lab before I joined the Seeley lab, Dr. Seeley became interested in exploring this phenomena of increased systemic bile acids after surgery. So the first thing they did is look at the role of FXR. Again, FXR being one of the bile acid signaling pathways, bile acid receptors. So here what I'm showing on the top is wild type mice. When wild type VSG mice go through surgery, sleeve gastrectomy, they have sustained body weight loss. However, what they found with the FXR knockout mice is that sustained body weight loss was lost in the knockout mice. And in addition to this, the FXR total body knockout mice, they did not have improvement in glucose tolerance. And when I joined the Seeley lab, we were really interested in exploring this further. And the question that we had is, what is upstream or maybe downstream of FXR that's regulating this? And the target that we settled on was the gut hormone FGF15, 19, and FGF15 is the mouse ortholog, FGF19 is the human ortholog. And today, to confuse you, I will show you both mouse and human data. So Yes, but it's the same thing, just different orthologs. And the reason why we became interested in FGF1519 is because it is a very well-known FXR target. It's regulated by FXR activation. It is released postprandially by the gut, by the ilioenterocytes. And it regulates, it's a potent regulator of bile acid synthesis. So after FGF15 is released by the ileum, it will travel through the portal circulation where it acts on the liver to suppress de novo bile acid synthesis. And in addition to this, pharmacological administration of FGF19 has very potent metabolic effects, including increased insulin secretion, glucose tolerance, as well as reduced food intake. Further, we know that FGF19 levels are regulated in the obese state. So this is data, this is our patient data looking at FGF19 levels in lean subjects and subjects with obesity. So FGF19 levels go down in subjects with obesity, and they go down even further when we have comorbidities such as type 2 diabetes and MASLD. And when we looked at the correlation of the FGF19 levels with BMI or blood glucose, we found that FGF19 correlates with BMI, but not with glucose levels. What about sleeve gastrectomy? I told you that FGF15 is expressed in the ileum. So when we look at the allele expression in our sleeve gastrectomy mice, we see that FGF15 expression is upregulated. And when we look at our patient cohorts, we see that the circulating levels of FGF19 are also increased after surgery. And this has also been shown by other groups, showing that FGF19 levels increase as early as day 7 post-surgery. So this is very early and weight-independent effects of vertical sleeve gastrectomy. So part 1, we asked the question, what is the role of gut FGF15 in mediating the beneficial effects of vertical sleeve gastrectomy? And we really approached this question with the hypothesis that the effects that we see of FGF15 will be very similar to the effects of FXR. This is the experimental paradigm that we use. We did have to make a new mouse model because the total body FGF15 mice are developmentally compromised. And one of the things, including seizures, one of the things that we discovered is that they do not gain weight on high-fat diet, which would have complicated this project. So we made a new mouse model, and we specifically ablated FGF15 in the gut in the adult mouse. So what we normally do is we feed mice 60% high-fat diet for about 8-9 weeks. After this, they're randomized between sham and VHG surgery. And what I'm going to show you here today is the wild-type mice will be in the black, and the FGF15 knockout mice will be in the color red. So going through the groups, we see that the sham mice continue gaining weight after surgery. The wild-type VHG mice have a sustained weight loss reduction, as we expect. We were really interested to see the body weight gain of the FGF15 knockout sham mice, again, because this was a new mouse model. And luckily, and we were excited about this, there was no difference in the body weight gain between the FGF15 knockout shams and the wild-type shams. And now, to our great surprise, and opposite of our hypothesis, we found that the knockout VHG mice lost a great amount of weight after surgery. Now, to remind you, what we expected to see is similar that the Sealy lab found in the FXR total body knockout mice. So we did not expect that these mice will have weight loss after surgery. We checked the food intake, and the food intake was not different between the groups. We also looked at the absorbable energy because the the second hypothesis we had is that maybe FGF15 is responsible for the malabsorption, that is trying to prevent the malabsorption after surgery. And what we found is that if anything, the knockout VHG mice are trying to absorb more energy. Now, I'm showing you this data with the caveat that we measured the absorbable energy at the end of these studies. So as you can imagine, at week 11, week 12, these mice are going into a lot of compensation processes. So what we're doing now is we're going back a little bit earlier, and we're going to measure the absorbable energy early when that rapid weight loss is happening. I think I froze. Oh, there we go. Great. So next what we wanted to do is look at the body compartments. Where is this weight loss coming from? And looking at the fat mass, both VHG groups lost adiposity, but it was not different. It was not statistically different between the wild type and the knockouts. And then we looked at the lean muscle mass. The lean muscle mass, when humans undergo rapid weight loss, they normally lose some amount of lean muscle mass. And this is true for bariatric surgery. However, what we find in our mouse models of sleeve gastrectomy is that the mice are very protective of their lean muscle mass. And we normally do not observe changes in lean muscle mass in mice that have sleeve gastrectomy. So this is what this data is showing. We don't see a big difference between the control shams and the control VHGs. However, to our surprise, the knockout VHGs had a great reduction in lean muscle mass. And this is, and actually, if we account this difference in lean muscle mass, the majority of the body weight loss that they had really came from lean muscle mass, loss in lean muscle mass. So just looking at lean muscle mass, and this is really fascinating to me because these are things that when we look at the positive effects of vertical sleeve gastrectomy, we mostly think of how much fat is the mouse losing, and the same with the patients. But this was really fascinating to me. So as I said, under any weight loss intervention, especially rapid weight loss intervention, we do have loss in lean muscle mass. And this could be up to 40% of the weight loss could be coming from lean muscle mass. But this is definitely something that we try to avoid because skeletal muscle mass is very important for insulin sensitivity as well as preserving energy expenditure. And this becomes really important because when a patient is losing weight and they're losing the lean muscle mass, energy expenditure will go down. And if that patient is at a position where weight regain could occur, they're really at a really bad outcomes point where that weight regain is much more likely at the given lower energy expenditure. So this is why preserving the lean muscle mass is very important. Just a little side note, I wanted to put some of the liver data in here because we found this very fascinating. So when we looked at the reduction in AOT after surgery, both VHG groups had reduction in AOT. But what we found is that the liver to body weight ratio in the knockout VHGs was increased after surgery. And when we looked further, we found that this increase in liver weight came from increased deposition of cholesterol. The knockout mice, again, these knockout mice are very small. They hardly have any fat, but their livers are bigger and the livers are full of cholesterol, both total cholesterol and esterified cholesterol. And looking at the cholesterol synthesis and the cholesterol transporters outside of the liver, we do see that the knockout VHGs are synthesizing less cholesterol, but the cholesterol export is downregulated. So that cholesterol is stuck inside their liver. We had wonderful pathologists look at these images, and something that they noted is that the knockout VHGs had the zonal injury patterns. And in particular, they saw this pale zone 3 around the central vein, which is associated with hypoxia, potentially secondary to chronic anemia. We also saw a great amount of microvesicular steatosis in these mice, and that is one of the indications for intestine failure-induced liver disease. Gets a little worse. We had, with the help of Zero Lee and Norman McDougald, who are at University of Michigan, we looked at the bone density of these mice. And the trabecular bone was decreased. We had published this before, and we knew that sleeve gastrectomy decreases the trabecular bone. But what was really interesting is that, particularly in the knockout VHGs, the cortical bone was greatly reduced as well. And then Zero Lee and Norman looked at the bone marrow adipose tissue. And I think these pictures speak 1,000 words, because just looking at the regulated, this is the proximal tibial, and looking at the regulated BMAT, it's reduced in both VHG groups. But the conserved BMAT, which is less regulated by obesity and weight loss, is nearly diminished in the knockout VHGs. So just to pause very briefly, I think you're aware at this point that I'm no longer talking about the positive metabolic effects of metabolic surgery. And unfortunately, these knockout VHG mice had a lot of complications and a great strong phenotype of strong malabsorption. So what we did is we looked at the literature and tried to find case studies of similar phenotypes, similar case reports being published in patients that have underwent bariatric surgery. And we found case reports where patients would report in the emergency department with profound weight loss, but also with liver decompensation and great sarcopenia. And this is after different versions of metabolic surgeries. And one of these case reports was by Dr. Nicholas Lantier, who reported 6 patients. All of the patients had liver decompensation without the presence of cirrhosis, and they had sarcopenia. So Dr. Lantier and I connected, and I shared with him our mouse observations, and ever since then, we've had wonderful discussions about this phenotype, and we're very interested in understanding the etiology of this sarcopenia and liver decompensation after metabolic surgery. And some of the proposed mechanisms Dr. Lantier had was that this could be a protein energy malnutrition, microbiome dysbiosis, or lipolysis and lipotoxicity. And a new hypothesis that him and I discussed is, could this be due to bile acid toxicity? And at this point, another patient from Dr. Lantier practices at the UC Lova at Brussels, Belgium. And another patient from another hospital in Belgium was referred to his service. And that patient had undergone Roux-en-Y gastric bypass, had jaundice of unknown origin, was undergoing liver decompensation, and histology showed that there was no presence of cirrhosis. They were able to measure lean muscle mass in the patient and show that she did have sarcopenia. And we were able to also measure bile acids in this patient, which were very high at 288 micromole per liter. And just as a reference, bariatric surgery is usually about 10 micromolar per liter. So great elevation of bile acids. So this brought us to the question, and this is not something we can test in these patients, but this is something, a hypothesis that we could go back to the mouse and measure and test. What is the role of bile acids after surgery, and how much becomes too much? When I showed you already, FGF15, 19 levels increase after surgery, and we see increase in systemic bile acids. But what I also showed you is that FGF15 is secreted by the gut and acts on the liver to suppress the de novo bile acid synthesis. So what happens to the bile acid levels of these mice? Again, here we see that the control VSGs have high increased levels of bile acids and changes in composition. The knockout chams also have increased bile acids and again, changes in composition. And that is because we're lacking that negative feedback from not having FGF15. However, when you don't have FGF15 and you put the mice through surgery, you have this massive increase in systemic bile acids. And in addition to this, if we look at the bile acids, which are labeled as hydrophobic bile acids, they were also greatly increased in the knockout VSG mice. And there's a lot more data in this paper, and this is published, but other things we observed is cardiac hypertrophy in these mice, a massive increase in erythropoietin and FGF23, which we think are some of the culprits in the loss in bone density. But the way we left the paper is we proposed that a lot of these changes that we see is due to the bile acid toxicity. So what I will show you from now on is a lot of new unpublished data really answering this question. So as part 2, we took a step back and we asked, what is the role of the increased systemic bile acids after surgery? And a second part of this question was, do these high levels of bile acids, what we refer to as bile acid toxicity, or is it the low levels of FGF15-19 contributing to the catabolic state in these mice? Yeah.
So some of the human data you showed us gastric bypass.
It's all bypass.
Yes.
They're all bypassed, right? So this is all vertical sleeve gastrectomy.
That's a great question. So I have not seen a single case report of this happening after vertical sleeve gastrectomy. But there are also no FGF15 deficient humans. So I think our mouse model really pushes this to the extreme. So I don't expect this to happen to a patient after vertical sleeve gastrectomy. I think this has to be more malabsorptive state, right? Maybe more of a malabsorptive surgery to push it to the state. And something that's also interesting to me, and I don't have the answer to this, is some of these case reports are patients that have had, for example, Roux-en-Y gastric bypass years before. And this is always my question, what is it that now pushes that state of liver decompensation and sarcopenia? Why now?
Yeah, when you look at case reports, there could be, okay, in these patients with liver failure, you found surgery, but how many other case reports are there where the liver failure occurs without cirrhosis, but they didn't have surgery? So you're picking out, that's not, I don't know, right?
You're wondering if the incidence is
Yes.
You could find, maybe other case reports of unexplained liver decompensation. You didn't look for them, right?
Yes.
So,
yes, yeah.
If you Google liver failure and bariatric surgery, these 6 pop out. But what about all the other case reports of liver failure where they didn't have? So I don't know. You see what
I see what you're saying. Yeah,
so,
I think that the reason that the bariatric surgery community has this on our radar, though, comes from the jejunal ileal bypass era, where there was a very dominant and known complication profile of the development of liver failure in those patients. And it's why the GI bypass was abandoned. And so we've seen a couple of these cases here since I've been here in about 10 years, maybe 2.
Yeah.
Where you get consulted in the MICU on someone who's in liver failure of unknown etiology and it is always a bypass. And it's usually this delayed presentation. And I think your point is well taken.
Right, they consulted you because
right, because I'm the bariatric surgeon.
Right, but they wouldn't consult you on others. That's what I'm saying. It's
a
problem if you are looking for something in case reports. It's not randomized control.
Yeah, but I think if we assume, let's just assume that it's a bypass physiology based on total bile acids. I don't know if that, I think though, you know, like at first you kind of go, well, why are you studying sleep gastrectomy? But I think you have a mouse model that can mimic the same bile acid physiology that we're seeing potentially clinically.
Yes, exactly. And you will see a lot of this data really points towards FGF15 more so than bile acids. And I think that's why, because there are no FGF15 deficient humans, but this is a totally FGF15 deficient mouse, I think we're pushing that phenotype, that system to like the extreme end. So to answer this question, we had to decrease systemic bile acids. And to do so, we decided to use an ASBT inhibitor. And the ASBT is an active transporter right over here. It's in the ileum. It sits in the brush border membrane. So when we inhibit ASBT, we inhibit the reabsorption of bile acids back into circulation, and therefore they're excreted. And the ASBT inhibitor we used was merolaxibat. It's FDA approved for pediatric patients with Alagille syndrome, and it's sold by the trade name Livmarli, Mirum Pharmaceuticals. And the experimental design that we used was very similar to the previous study. However, with the caveat that now we have 2 additional sleeve groups. We have the wild type sleeves that will receive merolaxibat, and we also have a knockout sleeve that will receive merolaxibat. And merolaxibat was formulated into the same diet, so we used the same batch diet, only one was had the merolaxibat. So I'm going to guide you through these figures because things get a little complicated, a lot more lines here. So here first we're showing the 2 sham groups, the knockout shams with the wild type shams, and there's no difference in their body weight. The wild type VHGs have reduced body weight, and that is sustained throughout the study. The knockout VHGs have reduced body weight, as we showed earlier, in treatment with merolaxibat, so in other words, decreasing the systemic bile acids did not rescue this. However, what was really interesting is that now the wild type mice, wild type sleeve treated with merolaxibat completely phenocopied the knockout VHG body weight loss. So then we went into our body compartments. We looked at fat mass. Fat mass was reduced in all sleeve groups. We looked at lean muscle mass. Again, wild type VHG mice do not have reduction in lean muscle mass. We do see a reduction in lean muscle mass in both knockout groups, so the knockout sleeve and the knockout sleeve that received merolaxibat. Merolaxibat was not able to rescue the decrease in lean muscle mass. But now the wild type mice, the wild type sleeves that received merolaxibat also had this loss in lean muscle mass. We looked at the bile acid levels, and again, VHG mice, sleeve mice, wild type mice have increased in bile acid levels. Merolaxibat was able to decrease those systemic bile acids very efficiently. And even in the knockout VHG that have these massive increase in systemic bile acids, merolaxibat was able to decrease these levels. So in conclusion, we do not believe that the systemic bile acids are responsible for the changes that we see in lean muscle mass. And we looked at FGF15 expression. I forgot to mention this earlier. We do not have an assay to measure mouse FGF15 levels, so we're using the ileo expression of FGF15 as a surrogate. And something that we found is that in addition to decreasing systemic bile acid, merolaxibat also leads to a compensatory decrease in FGF15. And when we correlate the FGF15 expression in the gut to the muscle mass of these mice, we see a positive correlation. And even though this is not final and this is not a conclusive data, I think it strongly suggests that it's not the bile acids, but it's the FGF15 levels that will that regulate the changes in lean muscle mass. but it's not all bad news. We did see very good improvements in the liver outcomes. We do see a lot less microvesicular steatosis after miralaxibad treatment, and we do see improvement in the NASH activity score. And this is really interesting to me, and I'm still trying to dissect this data, but this really uncouples the liver phenotype from the lean muscle mass phenotype, which I always thought came together, that maybe the changes that we see in the liver damage, is maybe contributing to the changes, the catabolic state that we see in the lean muscle mass, but this would really suggest that they are uncoupled. And this is a little bit off topic, but I think this is really interesting, and I wanted to include this in here. In addition to, we also see potent changes in the microbiome, both with vertical sleeve gastrectomy and after treatment with miralaxibad. Just to orient you here, we have richness of the microbiome and diversity of the microbiome. In all VSG groups, in the wild-type VSG and the knockout VSG, we do see increases in the diversity and richness. However, when we decrease the systemic bile acids, or we inhibit the reabsorption of bile acids, we lose that richness and we lose that diversity. And this really suggests that the bile acid changes that we see after surgery may really dictate what happens in the microbiome benefits after surgery. So the last part, this is a quick part, is when we look at the clinical data. And here we asked, is FGF19 necessary to maintain the lean muscle mass in humans after rapid weight loss? And to answer this question, we collaborated with Dr. Ian Schaefer and Dr. Karen Wu at UCSF, who have very well phenotyped vertical sleeve gastrectomy cohort. And again, in their patients, baseline 6 months and 12 months, we do see a gradual increase in the systemic FGF19 levels. And this correlates also to the changes that we see in the systemic bile acid levels. And when we look at the correlation of the changes in lean muscle mass to the changes in FGF19, we do see a positive correlation. And we're still dissecting and unpacking a lot of this data, a lot more to come.
Sorry.
Yeah.
So your change in lean muscle mass is, because we don't want a change in lean muscle mass, right? So wouldn't you want a negative correlation, right? You don't want a big delta in lean muscle mass as they lose weight.
No, but they do. So looking at how they lose muscle mass and correlating that with the changes that we see in the FGF19 levels.
So maybe you can just tell me, like, if the FGF19 change is big, what do you see in the lean mass change after surgery? A big change. It's a positive correlation.
Yes. Yeah. Yeah, I have to.
It's okay. Yeah.
At least that graph seems to show.
Yes, a positive. Yes.
No,
think about that.
Okay.
No, that one doesn't even have muscle mass. It's just after surgery.
Yeah. Okay.
And another, and then we asked another question. So we do see these changes after vertical sleeve gastrectomy. What if we look at another weight loss intervention? Is this a surgery-specific phenomena that we see, or is this true for undergoing rapid weight loss in another with another way? And what we decided to look at is a very low energy diet as a way of rapid weight loss reduction. And we did this in collaboration with Amy Rodberg and Charles Burant, a long-time mentors of mine, and this is through the Michigan Medicine Weight Management Program. And what Amy and Chuck have done is, this is an opt-in study through Blue Cross Blue Shield. And so patients opt in, they undergo very low energy diet in the forms of shakes, which is about 800 kilocalories per day. And the patients lose a lot of adiposity in addition to lean muscle mass. And when we look at FGF19 levels, we do see that in response to weight loss through diet restriction, we do see that FGF19 levels increase. And when we look at the data, again, we do see a correlation between the changes in lean muscle mass with the changes in FGF19 levels with these patients. But looking further into this data, we found that it's really the baseline FGF19 that dictated how much lean muscle mass these patients will lose after the intervention. And as last piece of validation, we wanted to see if this is also true in a diet-induced weight loss model using our FGF15 knockout mice. So we fed the mice wild type and knockout mice high-fat diet for 22 weeks, and then we just switched them on chow diet to lose weight. And sure enough, body weight reduction was the same, fat mass reduction was the same, but the knockout mice did lose more lean muscle mass in comparison to their chow. So just as summary, what I showed you today is that systemic bile acid levels and FGF15-19 levels increase after surgery. FGF15 plays an important role in the regulation of lean muscle mass after VHG. This was true in the human and the mouse model. We do not believe that these changes are dependent on the circulating levels of bile acids. We believe that this is a true gut to muscle interaction, and this is dependent on FGF15 levels. And what we see is that the lower baseline circulating FGF15 levels is significantly correlated with decreased lean muscle mass after diet-induced weight loss. So some of the remaining questions in clinical implementation, and I hope this can be a discussion about these findings, is we're going back to the basics, and we're asking the question, how does VHG alter bile acid metabolism? And what we did is we're using flux studies to answer this question. We're looking at traces of bile acids, isotope labeled bile acids, and seeing how they change between the sham and the VHG state in the different tissue compartments to really understand why is bile acid metabolism altered after surgery. We're asking, how do bile acids and FGF15-19 regulate nutrient handling by the gut after vertical sleeve gastrectomy? One experiment that we're doing a couple of weeks from now is looking at fat handling. I still am not truly convinced that this is not a model where these mice are malabsorbing. And we're trying to catch the right point where we can see how they're handling the nutrients after surgery, and is FGF15 playing a role in this. And the other thing that, and I hope this could be a discussion, what can we do to promote increase in FGF19 levels, maybe before the patients undergo rapid weight loss? If looking at the data from the diet-induced weight loss studies with Amy and Chuck, in the data suggesting that it's really the baseline FGF19 levels that are important in predicting how much lean muscle mass the patient will lose, is there something that we can do to upregulate these levels before the interventions? In ideas that I have, for example, Dr. Mike Schwartz from University of Washington has shown in very nice studies that protein is very potent, it's critical of very potent stimulant for FGF19 secretion. And when a subject consumes protein, FGF19 levels go up and they remain up for a long time, for hours afterwards. And something that I thought about is, for example, the pre-op diet, having high protein diet before surgery. Are we maybe serendipitously doing things already to increase those FGF19 levels before the patients undergo rapid weight loss? And with that, I would like to thank a lot of people. I try to acknowledge a lot of our collaborators throughout the talk, but everybody that has collaborated on the study is highlighted in red. Of course, my two primary mentors, Dr. Randy Seeley and Dr. Robert O'York. as well as our funding sources, the VA and NIH. And thank you again, all of you, for having me.
Any questions from the room? We have some graduate students back here and residents. And any questions online, feel free to send them in.
Yeah.
So this is kind of like a curiosity question, but so in patients that get the like intragastric balloon,
Yeah.
Do you also see a differential like bile acid profile, or is it only in patients who have like BSG in them?
That's
I
a
haven't
great
bile acid
question.
studied after the intragastric balloon, and I would say theoretically, I would suspect they are not elevated, but it gets down to mechanism. Which
Yeah.
is like we were talking about this earlier. What's the mechanism, right? Like, so we do a gastrectomy. We know emptying increases, gastric emptying increases. But some of your work suggests that's not the key.
Nope.
So that gets down to either neural signaling from the stomach or something related to the gastrectomy itself.
Mm-hmm. Transcriptional regulations in the liver. We know that, just as we discussed, a lot of the uptake, basically the recycling of bile acids through the liver, is decreased after surgery. And because that recycling is decreased, more bile acids remain in the systemic space, which is beneficial for the liver because bile acids are toxic. The liver does not want the bile acids. But at the same time, bile acid synthesis is downregulated in the liver as well. So yeah, nobody knows how this regulation is happening. And we are hoping to address some of these questions. We're working on the analysis of that big isotope tracer experiment, and hopefully we'll get some answers from that.
Would you mind sharing maybe with the group just some of the preliminary studies that you have with semaglutide?
Yes.
In which model this fits into? Is it diet? Is it more like diet induced? Is it more like surgery, or is it in its own space with like the lean muscle mass findings? And we looked at like bile acids and FGF15 with sema.
With sema, that's an excellent question. And this is so. First, someone just recently asked me, the semaglutide outer got FGF15 levels, and I cannot believe I never checked this, but I will. However, I did do the experiment. So I treated wild-type mice and FGF15 knockout mice. They were obese, on high-fat diet, and then we treated them with semaglutide for about a month. However, semaglutide is so potent in decreasing lean muscle mass that I did not see a difference between the wild types and the knockouts. So one of my students and I have an idea when we come back is to treat the mice with sema again, but take away the sema after a month and seeing how that weight rebounds and whether the knockouts will be able to rebound with their lean muscle mass to the same efficiency as the control. But we definitely see a lot more lean muscle mass changes with semaglutide treatment compared to the surgery.
And what's the role of FGF15 in skeletal muscle?
Yes, another excellent question. So there have been studies that have shown that treating sarcopenic mice with recombinant FGF19 improves lean muscle mass. And there's a lot of in vitro studies showing that too, that FGF15 can directly interact with the FGFR4 receptor on skeletal muscle, and that can lead to improved fiber size. One thing that I did not mention is that we also see decreased grip strength in our mice, and studies have shown that FGF19 treatment in sarcopenic models can also improve not only the lean muscle mass, but also the grip strength.
Any other questions?
So in your FGF, like the baseline level, is there a huge variability among people?
Yes, very big.
So when you mention, like, maybe there is some triggering of increase in levels, but it could also be, genetic variability.
Absolutely.
So the amount of like differences we see in response to any surgery or even weight loss could be natural, like genetic variability in people, right? So I don't know if even if you do trigger, because that's transient increase, right? So if you're saying like, okay, maybe we should do something before surgery or other weight loss so that they keep, but how long will it last if you're triggering it? You have to have natural ability to sustain that increase, right?
To sustain it. But the interesting part is when we look at that big data cohort, and we're really just starting to look at the vertical sleeve gastrectomy data, so I have more insight into the weight loss data, the VILAD model. We see patients that start with very high FGF19 levels, and they may not change after weight loss, right? Because most of the time, like we see that increase in FGF19 with increase in leanness or decrease in body weight. They may not change, but they're not the patients that are losing lean muscle mass, which is so interesting. So and this is something that once we started unpacking the data, is that yes, the whole delta does play a role, but like really looking at the R-square and like where we see the most confidence is when we start to dissect it into like, is it the baseline levels or is it the final levels of FGF19? And it's really the baseline that predict. So you're right, those baseline levels could be genetic variability.
One of the things that I would be really curious, and I wish you could have met with Dr. Grovey today, because this is just his thing, is, right, so you said caloric intake was normal between VSG and your FGF15 knockout, and food intake was the same between groups,
yep.
Right? But those body weight curves, VSG and the knockout, are just so incredible. I mean, that's energy expenditure, right? That's energy
yes.
expenditure. Okay, so have you done metabolic caging? Trying to sort out where's the energy deficit.
Yes.
Clearly, they've burnt off some skeletal muscle as part, but the energy deficit is there, and so I think that would be really interesting to see, like, or, right, as this group knows, like. Anaerobic metabolism, which comes from the gut microbiome,
yes,
can be 8-10% of energy expenditure. And so we see microbiome changes from the data. So is it actually not peripheral energy expenditure, but maybe an enhanced anaerobic metabolism from the gut that's responsible for that weight loss? And so those would be things that collaboration might be able to help you sort out through direct calorimetry.
Absolutely. I think this is fascinating. And we did just as bomb calorimetry, when I showed you the absorbable energy, we did the metabolic cages at the end of the study. So of course, the mice that had great reduction in lean muscle mass had very low energy expenditure. But this is a compensatory change at this point. So it didn't really tell us much. So now we have the same cohort that just went through surgery last week, and we are doing the metabolic cages, we're doing the absorbable energy right at that point when they're starting to lose the weight. And after this, we're looking at fat oxidation in these mice.
I have a question.
Yes, Sarah.
So knocking out FGF15 versus FXR has opposite effects.
Yes.
So would there be any utility in knocking out both in an animal to see what would happen, to see like what we could learn from losing both of those genes?
I think, yes, I would love to do this study actually, but I think it would be, it would have to be a specific, like either gut FXR or liver FXR, because research studies, now really great research studies, have shown us that it's the gut FXR that's responsible for the lipid absorption by the gut. And this is why one of the first things that I'm focusing on the FGF15 knockout mice is looking at the fat oxidation, because I think the gut FXR mimics more with what we see with our FGF15 knockout mice. And the liver FXR mostly just regulates the lipid synthesis in the liver. So it's, and they have very different phenotypes when it comes to metabolism. So maybe targeting, yes, one or the other in seeing, and because FGF15 plays a role in the gut, but it also plays a huge role in the liver as well. So yeah, uncoupling those I think will be really interesting. Great suggestion.
Yeah, this was also just another like curiosity question. So because you mentioned that like PSG patients have like that increase in like bile acid, like plasma bile acid pools. So is that, you might have mentioned it, is that sustained like years after? And do they also look at that in patients who come in that have had VSG with liver decompensation?
So the one case report that Dr. Nicholas Lantier and I published, I believe is the only case study where they measure, like where we measured bile acids, just because that was like one of the hypotheses that we had. Is it the bile acids? But I mean, in all honesty, like a patient undergoing liver decompensation is probably not super surprising to have like really high levels of bile acids. But it's just something we wanted to check, and we couldn't check FGF19 levels. So to answer your question, the first part is I have not seen bile acid levels in any of those other case reports, but I do believe that I think it's very variable between patients, but I have seen data on bile acid levels years after surgery remaining high.
Yeah, I know from bypass, I feel like I've seen more literature. Sleeve, I don't know how far out I've seen the data that they've checked. Interestingly, though, in terms of sustainability, there is like there was a recent publication with GLP-1 levels after sleeve gastrectomy, and it looks like it's kind of going away.
Oh, really?
Yeah.
Years after surgery?
Yeah, which may be why we don't see as robust a maintained weight loss if we believe GLP-1's important.
Yeah.
Weight loss, we argue about that for another hour. But some of these, there appears to be compensation and going back to baseline. That study that I saw was 4 years, and they've kind of lost their GLP-1 response at that point. So I don't know how long. After bypass, we've got better data, like, you know, looking like 10 years out, that there's still some sort of a response that's happening. But sleeve is interesting that way. And I don't know what the sustainability is going to be of some of these changes as we get far enough out to have cohorts where we can look like a decade out.
That's very interesting. Are those like, is the loss in the GLP-1 response correlated with the weight regain?
That study, I don't remember if they did weight loss response or not. I don't know if they had like enough pre-samples to really make it, like when they had a response and when they didn't have a response. I'll have to look at that a little bit closer. It's a good question.
That's very interesting.
Because there are no normative data. You don't know how much the GLP-1 should be.
Correct. That's the thing, is like it has to, right, it needs to be kind of a longitudinal study with enough subjects.
Yes.
Yeah.
Absolutely.
Yeah. And I just don't remember. I don't think that study was done that way. But we need to start collecting this data longitudinally, because I think we're going to be surprised at what happens long term with sleep. All right, well, it's 5:30, so
thank you so much. Thank you for having me. Thank you.
A lot of people online too, so I appreciate you doing a hybrid format, so we can
absolutely.
as many faculty and staff as possible.